Good morning to you all. Our next session in SLENDO 2023 is an expert panel discussion on harmonized care for thyroid disease in pregnancy, no Cliché. So I'm Dr. Indika Boteju, consultant physician at Castle Street Hospital for Women, and I will be moderating the session. And today we have for this discussion three eminent experts: consultant endocrinologist Dr. Kamani Liyanarachchi, and consultant endocrinologist Dr. Chandrika Subasinghe, and consultant endocrinologist Dr. Dharshini Karuppiah. So we will discuss about importance of thyroid disorders in pregnancy and physiological changes happening with regard to the thyroid function in pregnancy, and about conditions with elevated and reduced thyroid functions during pregnancy. To begin with, Dr. Kamani, could you please tell us about the importance and relevance of the thyroid disorders in the pregnancy in general?
Thank you, Dr. Boteju. So, can you move the next slide, please? Okay. So, abnormal, I have put in inverted commas. Abnormal thyroid functions in pregnancy are common. You will see why I have put this in inverted commas when we go through the physiology section. And the other reason is pregnant women, there is shared care given by a multitude of physicians from the primary care and also the gyn and obs specialists as well as the physicians who look after the hormone part. So there may be confusion among these clinicians who treat. And the other thing is overt thyroid dysfunction, both hyper and hypo, may have dire implications on pregnancy. So let's see what are the consequences of uncontrolled hyperthyroidism first. So it can cause spontaneous abortions, premature labor. It can increase chance of preeclampsia, as well as pregnancy could precipitate heart failure and thyroid storm. For the child, it can cause neonatal hyperthyroidism, IUGR, stillbirth, and prematurity. Complications of overt hypothyroidism are quite similar. For the mother, it can cause preeclampsia again, placental abruption, increased miscarriage and postpartum hemorrhage, risk of cesarean section, etc. For the fetus, again, preterm delivery, low birth weight, and increased perinatal mortality, and as well as neuro, psychological and cognitive impairment. Yes, Dr. Boteju.
Thank you, Kamani. And we know that pregnancy is a unique state and it has its own physiological changes. And with regard to thyroid, also the thyroid function is also the same. And Dr. Chandrika, would you be able to tell us about physiological changes occurring in thyroid physiology during pregnancy?
Yeah. Yes, Dr. Indika. So we know that there are several physiological changes take place in the thyroid during pregnancy. So knowing these changes are important in interpreting thyroid functions during pregnancy, as well to choose which patients need treatment and what are the indications for treatment in thyroid function changes during pregnancy. So if you look at this, you can see we know that beta HCG is secreted during early part of the gestation, and beta HCG shares similar alpha subunit with TSH. So because of this structural homology, the beta HCG could bind the TSH receptors and stimulate thyroid gland to produce increased levels of thyroid hormone. So through negative feedback, the increased levels of thyroid hormones will act on pituitary and hypothalamus to suppress the TSH levels. So when you look at the thyroid function test in early pregnancy, you will see suppressed TSH and increased thyroid hormone levels, which is a physiological change. And in addition to this main physiological change. So there can be some other changes take place during pregnancy. So we know there is increased levels of estrogen that will act on the liver to increase levels of hepatic thyroid binding globulin. So we know thyroid hormone is bound to thyroid binding globulin, TBG, in the circulation. So with increased TBG levels, there will be high levels of total T4 and total T3. So usually in practice in Sri Lanka, we do not measure total thyroid hormone levels, but we need to keep this in mind. And also in the placenta produce placental deiodinase 2 and 3 mostly. So this is the regulator of the maternofetal thyroid hormone transfer, and it causes degradation of the T4. So increasing the demand for thyroid hormone for the mother, production for the mother. And also there are a lot of changes take place in the iodide metabolism, where there will be iodide transfer to the placenta, and there will be increased iodide uptake from the thyroid gland for increased demand of thyroid hormone production, and also there will be increased urinary iodide losses. So because of that, in absence of iodine, universal iodine supplementation, there could be a high chance that the mother can go into iodine deficiency. So this graph shows you how the HCG, TSH, pre-T4, total T4 and thyroid binding globulin changes during pregnancy throughout the trimesters. In summary, so you can see the thyroid hormone production increases by about 40 to 50% according to the increased demand, and there will be increased levels of TBG, and the daily iodine requirement will be increased by 50%, and the gland size, because of the stimulation by the HCG, estrogen and TSH, there could be increase of the gland size by about 10 to 20%, and also there are some immunological changes take place in the pregnancy, which is the immunotolerant stage. So the thyroid antibody levels can change, especially in Graves' disease. Changes in the TRAB antibody levels can affect the natural cause of the disease during pregnancy. So few words about the fetal thyroid physiology. So we know the fetal thyroid start to develop around 5 to 6 weeks of gestation, and then it starts to produce its own thyroxine around 12 to 14 weeks of gestation, and come into its maximum capacity around 20 weeks. So in early gestation, it's very important to have good thyroxine replacement for the mother because the fetus is dependent on that. So those are the main physiological changes we have to keep in mind when we are interpreting, test and treating patients.
Thank you, Dharshini. Thank you, Chandrika, for that excellent talk. And dear Dharshini, we had a 32-year-old primary mother at her 10 weeks of gestation. She presented with vomiting and on and off palpitations, which is common in first trimester. And on examination, she had no eye signs and there was no goiter. And the TSH was depressed and free T4 was mildly, slightly elevated. So what is your plan of management and how to proceed for this mother?
All right, here we see a primary in early first trimester who has suppressed TSH and slightly elevated free T4. Next slide. So the question is how to proceed the patient with suppressed TSH and mild hyper. So what we are dealing with here, whether we are dealing with a thyrotoxicosis. So when you see the TSH level in pregnancy, you know, after the discussion about the physiology, there are so many changes. So we usually say the TSH is suppressed when it is less than 0.1. When it is very low, less than 0.01, we could say it's undetectable. And in the setup of suppressed or undetectable TSH and elevated free hormones or total hormones, the main differential diagnosis in a pregnant woman would encounter, the commonest one is the gestational transient thyrotoxicosis. The Graves' disease is the next common. The toxic multinodular goiter or toxic adenoma and the subacute painful or painless thyroiditis will be less common compared to the gestational transient thyrotoxicosis and Graves' disease. And we would encounter very rarely the TSH secreting pituitary adenoma and struma ovary. So the difference, the most common type of those two, how to differentiate, we need to have the clinical suspicion. So when there is a suppressed or undetectable TSH with concomitant elevated free T4, so whether it's an overt hypothyroidism, so what will be the cause? To see the gestational transient thyrotoxicosis, which is the commonest one, it's usually the HCG-mediated phenomena. So usually in the first trimester, we saw the example patient in her early first trimester. There are no eye signs, vomiting. So it's most probably, we could say it's gestational transient thyrotoxicosis. It usually happens in the early part of when the vomiting is high, and the similar explanation, the HCG has this molecular mimicry of the TSH, stimulate the thyroid gland. And then it's usually when there is HCG's excess level, the phenomena will be much common, like multiple pregnancy or hyperemesis gravidarum. So these patients most likely not having a features of like thyroid goiter or eye signs. So they have, when you see the further free hormones, they will be high T4 to T3 ratio. So these patients usually do not require antithyroid treatment. So supportive treatment in the case of hydration, and then if you need some further supportive management, you can give. On the other hand, the Graves' disease is less common than the gestational transient, but you have to have the clinical suspicion, especially if there is a past history of Graves' disease in this patient, or a family history, or the goiter or eye signs. You have to think about the Graves' disease present during pregnancy. They have, usually the TRAB antibody will be positive, and they have a high, relatively high free hormones compared to the gestational transient toxicosis, and the T3 to T4 ratio is high. They require antithyroid treatment. So this is the same graph as Chandrika mentioned, the level of the thyroid hormone and the HCG, if you see in the pregnancy. With the gestation, the early first trimester, the HCG level is peak, and then it will gradually reduce. So we need to do to confirm, or we need to do repeat examination when the HCG level is slightly low. So this is could be usually resolves in 14 to 18 weeks. So the patient, the question from the clinician and the mother will be, do I need any antithyroid drugs? Or gestational transient toxicosis, because it's mild and it usually resolves, no need of antithyroid drug. Reassurance is what they need, and the supportive management for the vomiting, and you need to repeat the thyroid function later when the HCG effect is slightly wean over. And you might give, if the patient having a tachycardia or some symptoms, you can give a beta blocker short course, 2 to 4 or 2 to 6 weeks.
Okay, thank you, Dharshini, Dr. Dharshini. And we will now move on to discuss another case, patient. Dr. Kamani, we had a 28-year-old lady with a period of gestation of 8 weeks. She presented with palpitations, sweating, nausea, and weight loss. And she had family history of thyroid disease as well. And on examination, she had a goiter, which was diffuse, and then there was some eye disease suggestive of eye signs suggestive of Graves' disease. And she has tachycardia. The blood pressure was normal. TSH was found to be low, and T4 and free T4 and T3 were fairly elevated. So could you please advise on further management of this patient? How can we manage this patient with regard to the pregnancy as well?
Thank you, Dr. Boteju. So here the most important question is, what is this patient having? Is it the gestational thyrotoxicosis, which is transient, or Graves' disease? So you can see from the history that the patient is having significant toxic symptoms, and there is also a family history of thyroid disease, which is pointing towards the Graves' disease. The more specific features of Graves' eye disease is also there, and then when you go through the thyroid functions, you can see that the TSH is quite suppressed with a significantly higher T3 than the T4. So these are the eye signs. So the diagnosis here is Graves' disease. So what are we going to do for this patient? Compared to the transient gestational thyrotoxicosis, here we need to treat them with definitive treatment, and also, like as in non-pregnant population, we give symptomatic treatment. So what about the antithyroid agents? So the issues with antithyroid agents are whether this can cause teratogenic effects. So when it came to large registries, population-based registries, Danish registries are there. So they found the teratogenicity, the adverse effects were quite similar when it came to propylthiouracil and carbimazole, which is about 2 to 4 live births. When it came to the transplacental transfer, it was first thought that PTU, because it was more albumin bound, it has less transfer to the fetus, but later on the studies show that the transplacental transfer is quite similar in these drugs. But the important question here is that carbimazole caused more severe teratogenic effects than the propylthiouracil. So these are the side effects of carbimazole: aplasia cutis, choanal and esophageal atresia. They also got abdominal wall defects like umbilicocele and VSD, whereas in PTU what they had was head and neck cyst and urinary tract abnormalities like renal cyst and hydronephrosis. Now these cystic lesions could be easily surgically removed. So the guidelines generally, I have quoted the American Thyroid Association guideline. It says in the first trimester to give propylthiouracil and then switch to carbimazole at the 16 weeks of POA. So the dose of switch is 1 to 20. For example, if the patient was on PTU 50 milligrams twice a day, the equivalent dose of methimazole would be 5 milligrams. So methimazole is the active component of carbimazole. So in Sri Lanka, we don't have methimazole actually. So what about, so this is the titration regime that we do. We don't do block and replacement therapy in pregnancy. So what is block and replacement therapy? It is where you give a high dose of antithyroid agent along with the thyroxine. Now, the reason why we don't give block and replacement therapy in pregnancy is because the placenta is readily permeable to antithyroid agents, but not so much to thyroxine, particularly following the second trimester. So this leads to, and the other reason, this leads to more passage of antithyroid agent rather than the thyroxine. And the other reason is fetal thyroid is relatively more sensitive to antithyroid agents than the maternal thyroid. So for these two reasons, by giving the block and replacement therapy, the child is at risk of getting, the fetus is at risk of getting goiter and hypothyroidism. So what about the symptomatic treatment or the beta blockers? It's considered in short term if there are severe thyrotoxic symptoms. So here we give the shortest course, shortest term and lowest dose. There are pregnancy safe beta blockers like labetalol, propranolol and metoprolol. The long-term use of beta blockers are thought to cause intrauterine growth restriction, fetal bradycardia, and neonatal hypoglycemia. And generally, it is believed atenolol should be best avoided because it's associated with more IUGR. So how do we monitor this mother? We do because free thyroid hormones are available for us. So we do the free T4 and TSH 2 to 4 weekly initially, and then 4 to 6 weekly once the target is achieved. Our target here is to maintain the free T4 just above the upper limit or at the upper limit of normal. This is again because the fetal thyroid is because the antithyroid drugs, agents pass through the placenta, and the fetal thyroid is more sensitive to the antithyroid agents. So we can't just, so the maternal thyroid, if you try to bring it to low normal, it can cause fetal hypothyroidism. So thyroidectomy is only given in special circumstances, only if there are severe allergies to antithyroid agents and very poor compliance despite our significant involvement in trying to improve the compliance, and also if we need a large dose of antithyroid agents. The second trimester is the optimal time because of the potential teratogenic effects of anesthetic agents in the first trimester and the risk of precipitating premature labor in the third trimester. So I think I have covered that area.
Yes, thanks Kamani. Thanks Kamani for that excellent explanation. And we now move on to the next case-based discussion. And Dr. Chandrika, we had a 30-year-old mother with Graves' disease, and she has come to the clinic and informs us that she is pregnant. And she had been on carbimazole for the last 14 months, but it was a low dose, carbimazole 5 milligram, and her last thyroid function test which was done was normal. And she was negative for thyroid receptor antibodies, and she wants to know if she should stop her medication or whether we have to continue on carbimazole or we have to change her to propylthiouracil or just wait and see. What is your opinion?
Yeah, thank you. So this is not a very uncommon scenario we come across in our endocrine clinics because we know Graves' disease is commonly prevalent or else relatively prevalent in the among fertile females. So whenever we come across a young female at fertile age with Graves' disease, at the time of diagnosis, we usually advise them to stabilize your thyroid function before becoming pregnant. But with or without controlling it, these people can get pregnant and come and tell you, look doctor, I'm pregnant now, what should I do? So as Kamani said, the antithyroid drugs has its own complications, but we have to prescribe antithyroid medications weighing the risk and benefits of it during pregnancy. So to understand what to do for a patient with Graves' disease when they become pregnant, we have to understand what is the natural cause of Graves' disease in pregnancy. So it has, as I previously said, in physiology, we know it is pregnancy is the immunotolerant stage. Because of that, these antibodies can reduce during pregnancy the thyroid receptor antibodies, TSH stimulating antibodies. So this study had shown how the antibodies has gone down during pregnancy throughout the trimesters. So one thing is, in most of the patients, the TRAB antibody levels will gradually go down, but when they are having very high basal TRAB levels, it might remain the same, and the patient can remain severely thyrotoxic as well throughout the pregnancy. So we have to keep all these in mind when we are taking treatment decisions. So because of this lowering of the TRAB levels, the Graves' disease severity can go down. So we might be able to tail off antithyroid medications and take them off the treatment at the latter part of the pregnancy. So at the beginning, so if the patient is having hyperthyroidism due to toxic multinodular goitoadenoma, so they are unlikely to remit. So we have to keep that as well in mind. So if your patient, when they become pregnant, come and tell you, so I am pregnant, so what to do? So we have to consider, if we stop antithyroid drugs considering its risk to the fetus, whether the patient is going to develop severe thyrotoxicosis or relapse. So to decide that, we have to look at the clinical scenario at the time of pregnancy. So if the patient is currently euthyroid on a very small dose of antithyroid medications, and if the patient has been on antithyroid medication for a longer period, and if she is having a small goiter, no eye signs, and if you can measure the TRAB level, if it is very low, in that case, if we stop medication, the chance of relapse of toxicosis is very minimal. So we can safely stop antithyroid drugs and monitor thyroid function test in 1 to 2 weeks in first trimester and less frequently later on. So on the other hand, if your patient is still hyperthyroid or requires high doses of antithyroid medication to maintain euthyroidism and has large goiter, eye signs, and had been on antithyroid medications for a shorter period, and if we can measure the TRAB levels and it is high, in that case, if we stop antithyroid drugs, the chance of relapse in severe toxicosis is high. So in that case, we will have to continue the antithyroid drugs as Kamani described earlier. So if the patient present before 16 weeks, we can convert the patient to PTU, or if it is already in the late second trimester, we can continue carbimazole or methimazole itself. So in Sri Lanka, we have only carbimazole. And also, what are the other monitoring we have to do in this patient? If the facilities are available at the time of diagnosis of pregnancy, we can do TRAB levels. And if it is high, then we can repeat it in the mid-gestation around 22 to 28 weeks. And if it's still high, then at the latter part of the pregnancy around 30 to 34 weeks. Because if it remains high in mid to late pregnancy, then we have to liaise with the obstetric team, fetal and neonatal specialists to monitor fetus for the fetal thyroid dysfunction. So that's how we should tackle with such a patient.
Yeah, thank you, Dr. Chandrika, for that excellent explanation. And Dr. Dharshini, may I ask a question from you now? If this patient, while on treatment for carbimazole, if she goes into delivers and goes into postpartum period, what are your thoughts about the postpartum mother having Graves' disease in the past?
Yeah, thanks, Indika. So when as the pregnancy period is an immune tolerance phase for most of the autoimmune diseases. Same for Graves' disease, the postpartum period will consider as an immunological rebound because there are dynamic changes occurring in both cellular and humoral immunity. So the postpartum period we usually define as the first year after the delivery. So this is a high risk moment for the relapse of Graves' disease. So what Dr. Chandrika said, if you give more than 6 months of antithyroid drug, the relapse rate is less. That also true for the postpartum period. So some studies says the continuation of the antithyroid drug throughout pregnancy associated with a reduction of the risk of relapse. But we know the risk of antithyroid drug for the mother and the fetus. And also we have to maintain the free T4 in mother in an upper normal range. So considering these facts, that is bit practically difficult. So this therapeutic option is not frequently we encounter because we need to protect the fetus from excessive level of antithyroid drug during gestation. Because of that, any women within the reproductive age, we have to advise on pregnancy, and also we have to tell about if there is a short duration of antithyroid drug before conceiving, there is a risk of postpartum relapse that is high. Yes.
Yeah, thank you, Dr. Dharshini. And Dr. Kamani, we would like to go back to another case-based discussion now. We got a 28-year-old lady who was complaining of extreme fatigue and mood instability and palpitations. Her baby was just 3 months old. And on examination, we found that she had tachycardia and blood pressure was normal and neck examination was normal and there were no eye signs to suggest Graves' disease. And the TSH was suppressed and the T4 and the T3 levels were marginally elevated. What can we do for this mother? Is it postpartum thyroiditis or Graves' disease? And whether to start any treatment, start carbimazole or propranolol, or order a radioactive iodine uptake scan on her for diagnosis.
Yes, Indika. So again, the diagnosis is important here. So the key points here is the baby 3 months and the patient is having some vague symptoms, fatigue, mood instability, but she has palpitations. If you look at the thyroid functions, the TSH is not undetectable, but it is suppressed. The free T4, if you look at the free T4, the normal range, it looks a bit higher than the free T3. You can look at the reference ranges. So T4 here is more than the T3, but there's actually a formula to use this. But generally, you can look at the numbers and see that the rise of T4 is more than the T3. So the management options depends on the diagnosis that we make. So let's see how we diagnose. Okay, so is this postpartum thyroiditis or Graves' disease? So what is postpartum thyroiditis? So it's actually an inflammation of the thyroid gland which causes release of the thyroid hormones, whereas Graves, so there is no actual increase in thyroid hormone production in postpartum thyroiditis, but in Graves' disease, it is due to the autoimmunity where the autoantibodies, the thyroid receptor antibodies act on the thyroid gland to produce thyroid hormone. So here in Graves' disease, you have high thyroid hormone production in the gland. So these are the two pathological, the basic differences in these two conditions. Now the postpartum thyroiditis actually occurs in the first 3 months of delivery. It can occur up to 1 year actually, but the commonest occurrence is within the first 3 to 4 months. Whereas Graves' disease, the common occurrence, this is due to the relapse of autoimmunity in the system. So Graves' disease commonly occurs after 6 months of delivery. And the other thing is clinically in patients with Graves' disease, they will have the Graves' specific symptoms like the goiter, bruit, eye signs, then they might have peritoneal myxedema, family history, etc. So when it comes to the thyroid hormone levels, that in postpartum thyroiditis, there is higher T3 than T4. The TPO or thyroid peroxidase antibodies, thyroglobulin antibodies will be positive, whereas the specific antibody for Graves' disease is the TRAB or TSH receptor antibody. If you happen to do the radioactive iodine scan, the scan will show low uptake in the postpartum thyroiditis, and that, as I mentioned, it is because the iodine uptake means the amount of thyroid hormone production in the gland, because iodine is a component of thyroid hormone. So if there is increased glandular production, there will be increase of iodine uptake. But here in postpartum thyroiditis, as I mentioned earlier, there is no increased production, it's just the release of stored hormones. But in Graves' disease, there will be increased radioactive uptake. Right, so now the thing is radioactive iodine uptake scan. So in Sri Lanka, we encourage mothers to breastfeed. So here it's a problem for us. But the I131 scan is absolutely contraindicated, but we can do technetium or I123, the short-acting iodine scans during breastfeeding, and then we can withhold express breast milk should not be given for the child for about 1 week, and then we can start breastfeeding. We are giving technetium or I123 scan. So the postpartum thyroiditis, the classic variation has a hyperthyroid phase which lasts for about 3 months, and then the hypothyroid phase, because there's actually a destruction of the thyroid tissue causing low thyroid hormones to be shown, and then there will be recovery. The important thing here is there will be some amount of patients who will be having permanent hypothyroidism. So it is important to monitor these patients later on as well for development of hypothyroidism. So the management depends on their symptoms. So here the hyperthyroid phase is usually mild compared to Graves' disease, and the antithyroid agents are ineffective because how these antithyroid agents act are by reducing the hormone production, the iodine coupling and all, to there are steps of thyroid hormone production. So here there is no increased reduction, so antithyroid drugs are ineffective. So the treatment is actually typical, symptoms are usually mild. It's symptomatic management during the hyperthyroid phase. Sometimes we might need beta blockers, so propranolol and metoprolol are recommended. And in the hypothyroid phase, you treat if symptomatic or if they are attempting pregnancy, and some say during breastfeeding time also because it will help the feeding. If treatment is initiated, if treatment is not initiated also during the hypothyroid phase, it is important to monitor their thyroid functions because some of them may go into permanent hypothyroidism. Yes, I think, yeah, we have come.
Yeah, thank you, Dr. Kamani, for that excellent explanation. And I think now we have discussed a fair amount of conditions with elevated thyroxine levels during pregnancy. And now we will move to discuss about reduced thyroxine levels, low thyroxine levels during pregnancy. And Dr. Chandrika, what do you think about this low thyroxine levels, hypothyroidism and pregnancy? Do you have any comments?
So I think, so hypothyroidism, so let's talk about the management of overt hypothyroidism in pregnancy first. I don't have the prevalence of primary hypothyroidism in pregnancy in Sri Lanka, but by experience anyone would agree that it is the commonest thyroid dysfunction we see in pregnancy. As in general population, the commonest cause is autoimmune thyroiditis. So if we happen to diagnose a patient with overt hypothyroidism for the first time in pregnancy, so if the TSH is more than 10 and with low T4, it's a clear overt hypothyroidism, then we have to start them on full replacement therapy unless there are contraindication to start high dose thyroxine, which usually does not happen in pregnancy. So as I said, in physiological changes in pregnancy, the thyroid hormone demand or the requirement is high. So in general population, we see the daily requirement of thyroxine is about 1.6 microgram per kilogram per day, but here we start higher doses like 2.3 micrograms per kilograms per day, and the patient will need increments of thyroxine up to about 20 weeks, and thereafter most of the time it's stabilized. And on the other hand, if one of our known patients with hypothyroidism who is already on thyroxine treatment wants to get pregnant, when they are planning for pregnancy, always like in thyrotoxicosis, if we have a hypothyroid patient in fertile age, we usually need to discuss the pregnancy planning with them, and we try to keep their TSH target a bit lower, less than 2.5, to prevent early hypothyroidism in early pregnancy with the current thyroxine replacement. Once the pregnancy is detected, the patient will need increase in their thyroxine replacement, so we can advise the patient safely to increase their dose by about 20 to 30% or to administer 2 additional doses per week. Like if you are taking 100 micrograms per day, so they can take 2 tablets of 100 micrograms per week additionally. So as I said, the increments will plateau around 16 to 20 weeks, and usually we keep the target for TSH less than 2.5 milli international units per liter. So not like in general population, we do frequent monitoring of thyroid function, initially 2 to 4 weeks and then less frequently. And then after delivery, the thyroxine demand, when increased demand is removed, so we can reduce the thyroxine dose to the pre-pregnancy dose. And if the patient was started on low dose thyroxine during pregnancy, maybe less than 50 micrograms, probably we will be able to stop thyroxine. And if we stop thyroxine or if we change the thyroxine, we have to repeat the TSH levels in about 6 weeks postpartum to assess the thyroid function. And if the patient is adequately replaced, we do not need special other maternal or fetal monitoring other than TSH monitoring, and we can do pre-T4 if we are thinking in terms of poor compliance. But if the patient is hypothyroid secondary to thyroidectomy or radioiodine ablation for Graves' disease, we in settings where we have facilities, we can monitor TRAB antibody levels, thyroid stimulation antibodies, thyroid blocking antibodies, in the early pregnancy, mid-gestation and late pregnancy as indicated, because it will guide us if it is positive for thyroid dysfunction, either fetal hyper or hypothyroidism, where we have to liaise with the fetal neonatal teams.
Thank you, Chandrika, for that excellent explanation. And Dharshini, we will now move into another case-based discussion. We had a 28-year-old lady in her period of gestation 10 weeks, and thyroid functions were performed for evaluation of her goiter. And there was no past history of thyroid disease. Her pulse rate and the blood pressure were normal. And the TSH was marginally elevated in the subclinical range. And free T4 was normal, and thyroid peroxidase antibodies were positive. So is this subclinical hypothyroidism in pregnancy or just an elevation of TSH? Or how to reassure the patient, and whether we need to start on thyroxine or whether we need to repeat the thyroid function test in 6 weeks? What are your thoughts, Dharshini?
Yes, Indika. So when you see a pregnancy in overt hypothyroidism, there is no much doubt on whether to treat or not treat, so it's straightforward. But when there is a subclinical range, we need to know, the subclinical hypothyroidism, whether to treat it or not is really a topic of debate. So if you see the physiology of TSH, the normal TSH for pregnancy, as you all know, there is a slight difference compared to the general population. For the general population, non-pregnant, so we take TSH within normal range, roughly it may be vary, but it's 0.5 to 4.5 or 4.7. But there is a downward shift of TSH in pregnancy. So in the first trimester, there is about 0.4 milli-international unit reduction, and it will gradually return towards the non-pregnant range in the second and third trimester. So what is the take as a normal TSH? The ATA 2017 guideline recommend the first trimester, it's a upper limit of normal considered as 4, and it will gradually return to non-pregnant range. But our Sri Lankan thyroid guideline, we take the first trimester TSH is 2.5, less than 2.5, and second and third trimester less than 3. So there are problems with whether the subclinical hypothyroidism in pregnancy associated with pregnancy loss or premature delivery, or any other complications related to fetus and mother. So there are some studies show there are may be associated with problem with premature delivery and low birth weight, and it can affect the neurobehavioral development of the fetus. But other studies show it's not much getting effect in terms of these problems as well. When you treat the patients with subclinical hypothyroidism with thyroxine, it failed to show a better cognitive outcome in offspring. So there is an inconsistent data whether to treat or not treat the subclinical hypothyroidism detected during pregnancy. So this may be, you see as a bit of a crowded slide, but if you see the TSH above upper limit of normal, so if you see the red circle line, that is overt hypothyroidism, TSH above 10, there is a no doubt, you start treatment with thyroxine. Only the difference is normal population we treat with 1.6 microgram per kilogram. Here we treat, as Chandrika said, higher dose 2.33. But in other people, that is less than 10 TSH, there is a algorithm to follow, or it will guide you. So then the antibody levels will be important in this subset of patients. So when there is a TPO antibody positive, the TSH within very mildly elevated, that is 2.5 to upper limit of normal, we can consider treatment depending on many other like goiter, family history, or any symptoms present. But if TSH is upper limit of normal to 10, that is a bit elevated than the first category, you can start the treatment, but the dose is lower than when it is TSH more than 10, that is 1.42 microgram. If you move to the TPO antibody negative subsets, TSH very mild, that is 2.5 to upper limit of normal, usually treatment not recommended. But when there is a slightly elevated, that is upper limit to 10, you can consider treatment based on the other risk factors. But as I said, TSH above, you can treat with a high dose. Few words about the isolated hypothyroxidemia in pregnancy, because that is one other scenario we usually encounter as a referral from GPs as well as obstetric colleagues. So there it's a similar to the subclinical hypo, but other way, the normal TSH, but the free T4 low, that is lower 2.5 to 5th percentile. Whether these need treatment, whether it requires treatment, whether there is any benefit on treating this isolated hypothyroxemia. In a non-pregnant female, you may say normal TSH and low free T4 could be other possible differential is secondary hypo, that is a pituitary, but here we know that the isolated hypothyroxemia is the common. So the known factor is, it's a common disease, may be associated with iodine deficiency, some environmental pollution and obesity. Some studies show it may negatively affect child's mental and motor development, but we haven't got any data whether the risk factors and underlying pathophysiological mechanism for this isolated hypothyroxemia, and whether on the effect of pregnancy and complications, and mental and motor function in later of the life of the offspring, and effects of treatment early in the first trimester, whether it's needed. So here, usually the isolated hypothyroxemia treatment is not recommended. That's all, yeah.
Yeah, thank you, Dr. Dharshini. And Dr. Kamani, and I think that she has mentioned about the thyroid peroxidase antibodies, TPO antibodies. So we have some patients who are getting pregnant, but they are euthyroid, but their TPO antibodies are positive. What is your opinion with regard to those mothers?
Yes, thank you, Indika. So we have this TPO antibody levels being checked in the government sector until recently. So compared to the TSH receptor antibodies, this was more freely done in the government sector. So we may have some patients who have TPO antibody positive, but they are euthyroid. So what are the implications, and should we follow them up during pregnancy? So the issues with this antibody is, the first issue is there is a higher tendency for them to develop abnormal or basically hypothyroidism during pregnancy. So the ATA guidelines, which the latest one is in 2017, it recommends that if your patient is TPO or thyroglobulin antibody positive, they should have a follow-up TSH conducted monthly till mid-pregnancy. Following that, actually these autoantibodies go down. So they recommend screening till mid-pregnancy. So this is a strong recommendation from the ATA. The other problem with the TPO antibody is it may associate with some pregnancy loss. So these are some observational data. Some association was observed with spontaneous pregnancy loss, but it was not proven. There was no causality or mechanism found for this. And there may be a association with recurrent pregnancy loss, but this association was less robust. So here comes a question. In a female who wants to conceive, who had recurrent abortions and TPO antibody is positive, and she wants a child. So is there a place for giving thyroxine or any other drug for this mother, for this lady? So here in 2017, the American Thyroid Association mentioned there is insufficient evidence to give thyroxine for this type of patients. But they also mention TPO positive euthyroid, however, administration of levothyroxine to TPO positive euthyroid women with a prior history of loss may be given a small dose of thyroxine. So this is because at that time they didn't have enough evidence. So in 2019, the tablet study is not working. Right, it's coming now. So in NEJM, they published, this is a UK-based study with a lot of data, a lot of patients in several centers. It's not working again. So here they found that there is actually no place. They looked at, they gave thyroxine to patients, to women who were infertile as well as who had miscarriages. So they gave thyroxine at a low dose and then they checked whether there was any increase in live birth rates. But actually the results came and the conclusion was there is no improvement in live birth. So actually when the new ATA guideline comes, they will give a clear thing that there is no place of giving thyroxine for this this group of patients. That's it.
Yeah, thank you, Dr. Kamani, for that explanation. And Dr. Chandrika, would you be able to let us know? Sometimes we find pregnant mothers coming with goiters, and we find suspicious nodules on the ultrasound. So how to proceed on these patients who were first diagnosed to have suspicious nodules in the thyroid gland during pregnancy?
Yeah, so we know the detection of thyroid nodule in general population also increasing because of the frequent use of ultrasound, freely availability of ultrasound scan for the patients. So if you look at the prevalence of thyroid cancer and thyroid nodules, so this is the commonest age group and females show higher prevalence. So if you look at the prevalence of thyroid nodules in pregnancy, it is reported as about 3 to 20%, and it has been shown that the prevalence increases with parity. So a lot of studies have shown that pregnancy is associated with increase in size of pre-existing thyroid nodules, as well as newly developed thyroid nodules had been identified during pregnancy increasingly. So they think that it could be the iodine deficiency, the stimulating effects of TSH, and the beta-HCG and estrogen plays a role in increase in number and size of thyroid nodules. And also there are studies which have shown that the growth of thyroid cancers and detected during pregnancy is rapid, and there can be worsening of the cancer characteristics during pregnancy, but also the studies have shown the different treatment or different surgery for these differentiated thyroid carcinoma detected during pregnancy to postpartum period has not changed the survival. So that has not affected the survival. So because of that, we can defer surgery in DTCs detected during pregnancy safely. That has been something well proven. So if you detect a thyroid nodule during pregnancy, what we should do, the algorithm, how we should assess that patient is, there is no difference from general population. So you go through history and examination, look for risk factors, then imaging, ultrasound scan, same non-pregnant criteria. If you use thyroids, you can use it. It has been shown that the pregnancy does not affect the ultrasound findings in thyroid nodules and detection of suspicious features. And we know the radionuclide scanning is contraindicated. So even if we find a hot nodule, in a thyrotoxic patient, we can't perform radionuclide scanning. So when we do TSH, if we find it to be suppressed, so you have to wait about 16 weeks and see if it still remains suppressed. In that case, we can defer the FNA suspecting thyrotoxicosity and probability of hot nodule. And the fine needle aspiration, we need to offer using the same ultrasound criteria and history and examination even in pregnancy. And it is safe at any trimester. You can perform the FNA safely. And the cytology, it has been found that the cytology is not altered by pregnancy. So same criteria again, same Bethesda or Thai criteria can be applied here. So what we can do for a thyroid nodule detected during pregnancy. So if a thyroid nodule is cytologically benign, that means probably the Bethesda 2, we do not require special surveillance. But if the benign nodule is rapidly increasing in size, or if there are ultrasound changes which are suspicious for malignancy, then that nodule probably need further evaluation and repeat FNA. And then if we have a cytologically indeterminate nodule in the absence of metastatic disease, or if it is, we can defer the surgery until postpartum period. But if there are clinical suspicion of aggressive behavior during pregnancy, we might consider surgery. And we can monitor these nodules with ultrasound scan for the growth. And molecular testing we usually use for the indeterminate nodules in general population, but these are not tested for sensitivity and specificity in pregnancy, so those are not usually recommended. And if we newly diagnose a differential thyroid carcinoma during pregnancy, and there is a possibility it can grow, so we have to monitor it. And surgery, if it is before the mid-gestation, during third trimester, if it is growing and if there are malignant cervical nodes are present, surgery could be considered, but it should be done in the second trimester. And if it remains stable by mid-gestation, or if it is diagnosed in the second half of the pregnancy, we can defer the surgery until delivery.
Thank you, Dr. Chandrika, for that explanation. And Dr. Dharshini, now we have another case-based discussion for you. There's a 28-year-old lady presenting with past history of papillary cancer, and she was on levothyroxine 200 micrograms daily. And so she's in her pregnancy period of gestation 7 weeks. What are your thoughts? Do we have to continue with the previous TSH targets, or whether we have to we have different targets for this patient?
Yes, now we also encounter the women who underwent surgery and medication for the thyroid cancers are coming for after the pregnancy. So for pregnancy, as we all know, the radioactive iodine is contraindicated for the 6 months. So pregnancy should be deferred 6 months after receiving radioactive iodine. But when you see when they come for pregnancy, they were treated previously. So we all know, depending on the severity of the thyroid cancer or extent of thyroid cancer, there is a TSH target. Maybe 0.5 to 0.5 or less than 0.1 to less than 0.01. So that target should remain as determined by preconception. So we keep it the same target even if they're pregnant. So there is no change on that. But there should be, the TSH monitoring should be a bit frequent, approximately every 4 weeks until the end of the first trimester, and then you can do once between the 26 to 32 weeks. But if you see the women who previously treated with differentiated thyroid cancer, who have undetectable serum thyroglobulin and are classified as having no biochemical or structural evidence of disease prior to pregnancy, that means clear from the disease, very less risk patients. So they do not require ultrasound or thyroglobulin monitoring during pregnancy. And other subset of patients diagnosed with microcarcinoma who may, under active surveillance than the surgical treatment, they should have ultrasound monitoring for their thyroid performed each trimester during pregnancy. These are the general recommendations for the subsequent pregnancy in women with thyroid cancer by the thyroid cancer guidelines.
Okay, now I think
like we have run out of time.
Yes, we have run out of time, and it brings us to the end of this expert panel discussion on thyroid disorders in pregnancy, no cliché. If you have any questions, or else can I ask a question from Dr. All of you? Now is a patient having Graves' disease, a normal woman having Graves' disease, and she's on treatment. So she has pregnancy wishes. What is your advice for that patient?
Yes, as I previously said, so it's common in the among fertile females. So when they are diagnosed with Graves' disease, we always have to kind of plan their pregnancy with them. So we need to tell them that you need to stabilize your thyroid function before you go into pregnancy. We can discuss whether you want the medical therapy, whether you are going for thyroidectomy or radioiodine. But if they undergo a radioiodine therapy, as Dharshini said, so they have to wait 6 months for the pregnancy, and also like initial stages after radioiodine, the TRAB antibody levels can be high. So if they undergo thyroidectomy or radioiodine, when facilities are available, TRAB levels should be monitored during pregnancy, and thyroid replacement should be optimal. So we need to discuss these things prior to pregnancy.
Okay, thank you, Dr. Chandrika. And I would like to thank all our expert panelists, consultant endocrinologist Dr. Kamani Liyanarachchi, consultant endocrinologist Dr. Chandrika Subasinghe, and consultant endocrinologist Dr. Dharshini Karuppiah. Shall we show our gratitude with usual manner for all three of our panelists? Thank you.
Thank you.